Are you one of the millions of men with diabetes who feels like you're fighting a silent, frustrating battle with erectile dysfunction? The common solutions, while helpful, often miss the foundational issues that are unique to diabetes. In the United States, where diabetes is a significant health challenge, understanding these nuanced connections is critical. We're not just going to rehash the basics today. We're going to explore 7 specific science-backed ways to directly address and fix diabetic erectile dysfunction, moving beyond the surface-level tips to give you strategies that can make a real, lasting difference. First, gain precise glycemic control. This is far more than just a casual check of your blood sugar now and then. Precise glycemic control is the rigorous, moment-to-moment management of your blood glucose levels, keeping them within a tight, optimal range as consistently as possible. For many, this means aiming for a hemoglobin A1C, which is a measure of your average blood sugar over 2 to 3 months below 7%. It involves understanding how every meal, every activity, and even your stress levels impact your glucose, and then making constant, informed adjustments. It's about moving from a reactive approach, treating high or low blood sugars after they happen, to a proactive strategy that prevents extreme fluctuations in the first place. This level of control is the absolute bedrock of managing all diabetic complications, and erectile function is one of the most sensitive indicators of how well you're doing. It's not just about avoiding sugar, it's about mastering your metabolism on a whole new level. The science behind why this is so crucial is direct and unforgiving. Erections are fundamentally a cardiovascular event. They depend on healthy, responsive blood vessels and well-functioning nerves. Chronic high blood sugar, a state known as hyperglycemia, systematically destroys both. Think of sugar in your bloodstream like tiny shards of glass. Over time, these molecules cause direct damage to the delicate inner lining of your arteries, a layer called the endothelium. This damage triggers a process called endothelial dysfunction. A healthy endothelium produces a critical molecule, nitric oxide, which acts as a powerful vasodilator, meaning it signals the smooth muscles in your arteries to relax. In the penis, this relaxation allows blood to rush into the corpus cavernosum, the 2 sponge-like chambers, creating the pressure that leads to an erection. When hyperglycemia damages the endothelium, nitric oxide production plummets. Your blood vessels become stiff and less responsive, a condition known as atherosclerosis, and they can no longer dilate properly when you're aroused. Furthermore, high glucose levels lead to the creation of advanced glycation end products, or AGEs. These are harmful compounds that form when sugar molecules bind to proteins and fats, causing them to become stiff and dysfunctional, further contributing to vascular damage. At the same time, hyperglycemia is toxic to nerves. It impairs their ability to transmit signals effectively, leading to diabetic neuropathy. The nerves that control the erectile process are particularly vulnerable. So, even if your brain sends the right signals for arousal, the damaged nerves can't relay that message to the blood vessels in the penis. It's a 2-pronged attack. The plumbing is clogged and rusting, and the electrical wiring is frayed. The consequence of ignoring this fundamental step is that every other treatment becomes less effective, or, in some cases, completely ineffective. You can be prescribed the most powerful erectile dysfunction medication, but if your blood vessels are too damaged to respond and your nerves can't transmit the signals, the medication will have a severely limited effect. Phosphodiesterase type 5 inhibitors, the class of drugs that includes medications like sildenafil and tadalafil, work by enhancing the effects of nitric oxide. But if your body isn't producing enough nitric oxide to begin with because of endothelial dysfunction, the medication has very little to work with. It's like pressing the accelerator in a car that has no gas in the tank. This is why many men with diabetes find that these medications either don't work for them or lose their effectiveness over time. It's not necessarily the drug that's failing. It's the underlying physiological environment that is too compromised. Ignoring glycemic control is choosing to treat a symptom while allowing the root cause of the disease to run rampant, causing progressive and, in some cases, irreversible damage, not just to your sexual function, but to your heart, kidneys, eyes, and feet. Your sexual health is a direct reflection of your overall vascular and neurological health. Think of erectile dysfunction as a canary in the coal mine, a potent early warning sign that significant systemic damage is occurring throughout your body. The solution starts with diligent and detailed monitoring. This often means moving beyond simple finger prick tests and embracing technology like a continuous glucose monitor, or CGM. A CGM provides a constant stream of data, showing you exactly how your body is reacting in real time. This allows you to identify patterns and make precise adjustments to your diet, exercise, and medication. Work closely with your endocrinologist or diabetes care team to interpret this data and set aggressive but achievable A1C targets. Your diet needs to be optimized not just for weight loss, but specifically for blood sugar stability. This means focusing on whole, unprocessed foods, lean proteins, healthy fats, and high-fiber carbohydrates that are digested slowly. Understanding the glycemic index and glycemic load of foods is essential. The glycemic index is a rating system for foods containing carbohydrates, showing how quickly each food affects your blood sugar level when that food is eaten on its own. The glycemic load takes into account the amount of carbohydrate in a portion of food. Strategic exercise, including both aerobic and resistance training, is also critical as it improves your body's sensitivity to insulin, allowing it to use glucose more efficiently. This isn't just a suggestion, it is the most important and foundational step you can take. If you get this right, all subsequent steps will be far more effective. Does this feel familiar? You've eaten healthy all day, but your evening blood sugar is still high. Let's break down why. Mastering this level of control is the key that unlocks the potential for all other treatments to succeed and offers the best chance at not just managing, but potentially reversing the vascular damage contributing to your erectile dysfunction. Implement a vasoprotective diet. This concept goes a significant step beyond the generic diabetic diet that primarily focuses on carbohydrate counting and sugar avoidance. A vasoprotective diet is a strategic eating plan specifically designed to protect, heal, and improve the function of your blood vessels, your entire vascular system. The core principle is to combat the three primary drivers of diabetic vascular damage: inflammation, oxidative stress, and endothelial dysfunction. It's not just about what you don't eat, like processed sugars and refined grains. It's very much about what you do eat. This diet is rich in specific nutrients, antioxidants, and compounds that actively fight against the hardening and narrowing of your arteries. It's about consuming foods that naturally boost your body's production of nitric oxide, the critical molecule for vasodilation and healthy blood flow. Think of it as nutritional therapy for your arteries. While standard diabetic diets aim to manage glucose, a vasoprotective diet aims to rebuild the very infrastructure that diabetes attacks, creating a more resilient and responsive cardiovascular system from the inside out. This is a targeted, therapeutic approach to eating that supports erectile function at its most fundamental level: the health of your blood vessels. The scientific explanation for why a vasoprotective diet is so effective lies in its ability to directly counteract the pathological processes of diabetes. Chronic inflammation is a hallmark of type 2 diabetes and is a major contributor to atherosclerosis, the stiffening of arteries. A vasoprotective diet is inherently anti-inflammatory. Foods like fatty fish, which are high in omega-3 fatty acids, as well as nuts, seeds, and olive oil, provide powerful anti-inflammatory compounds that cool down this systemic inflammation. Secondly, hyperglycemia generates a massive amount of oxidative stress. This is a state where there's an imbalance between free radicals, unstable molecules that damage cells, and antioxidants, which neutralize them. Oxidative stress directly damages the endothelial cells lining your arteries and depletes nitric oxide. A vasoprotective diet is loaded with antioxidants. Brightly colored fruits and vegetables, like berries, spinach, and bell peppers, are packed with flavonoids and polyphenols. These compounds are potent antioxidants that scavenge free radicals, protecting your blood vessels from damage. Specifically, certain foods can directly boost nitric oxide production. Leafy green vegetables like spinach and arugula, as well as beets, are high in nitrates. Your body can convert these dietary nitrates into nitric oxide. This provides an alternative pathway for producing this vital vasodilator, which is particularly important when endothelial dysfunction has impaired your body's primary nitric oxide production pathway. Furthermore, foods rich in the amino acid L-arginine, such as nuts, seeds, and poultry, provide the raw material your body uses to synthesize nitric oxide. Other compounds like quercetin, found in apples and onions, and citrulline, found in watermelon, also support vascular health and nitric oxide availability. It's a multifaceted nutritional attack on the root causes of poor blood flow. The consequence of overlooking this targeted dietary strategy is that you leave your blood vessels in a constant state of vulnerability and decline. A standard low-sugar diet might help control your A1C, but it may not be enough to reverse existing vascular damage or prevent its progression. You can be taking medication to lower your blood sugar, but if your diet is still pro-inflammatory and low in antioxidants, you are essentially fighting a fire with one hand while feeding it with the other. This ongoing vascular damage is the primary reason erectile dysfunction in men with diabetes is so common and often so severe, affecting them on average 10 to 15 years earlier than men without diabetes. Studies show that over 50% of men with diabetes will experience some degree of erectile dysfunction. When your arteries are stiff, inflamed, and unable to produce enough nitric oxide, achieving an erection becomes a physiological impossibility. It's a direct reflection of systemic disease. This is why erectile dysfunction in a man with diabetes is considered a strong predictor of future cardiovascular events, like a heart attack or stroke. The small arteries in the penis are often the first to show signs of damage because of their size. If they are blocked and dysfunctional, it is highly likely that the larger arteries supplying your heart and brain are also in a state of disease. Ignoring the call to adopt a vasoprotective diet means you are not only compromising your sexual health, but are also failing to address the underlying disease process that is threatening your life. The solution is a conscious and consistent shift in your eating habits towards foods that actively promote vascular health. This means making a list and actively incorporating these foods into your daily meals. For antioxidants, aim to eat the rainbow, including a wide variety of colorful fruits and vegetables at every meal. Berries, dark leafy greens, red cabbage, and sweet potatoes are excellent choices. For nitrates, make spinach, arugula, and beet staples in your diet. A daily salad with these greens can make a significant difference. You can even find beet juice or beet powder supplements, which have been shown in studies to improve blood pressure and blood flow. For healthy, anti-inflammatory fats, focus on sources like avocados, olive oil, nuts, and seeds. Fatty fish like salmon, mackerel, and sardines should be consumed at least twice a week for their potent omega-3 content. To boost L-arginine, include lean poultry, pumpkin seeds, and walnuts. It's also about what you strictly limit or eliminate. Processed foods, trans fats, sugary drinks, and excessive amounts of red meat, all of which are pro-inflammatory and contribute to vascular damage. If you just had a light bulb moment from that tip, tapping the like button is a free way to support the channel. It's a complete lifestyle overhaul, but the payoff is immense. This isn't just about erectile function, it's about fundamentally changing the trajectory of your diabetes and your overall health. Engage in targeted pelvic floor therapy. This is a highly specific and often overlooked form of physical therapy that focuses on strengthening a group of muscles collectively known as the pelvic floor. These muscles form a sling-like hammock at the base of your pelvis, supporting your bladder and bowel, and playing a critical direct role in erectile function. For men, this therapy involves more than just generic Kegel exercises. It requires identifying, isolating, and then methodically strengthening key muscles like the bulbospongiosus and ischiocavernosus. These specific muscles are essential for trapping blood in the penis to maintain a rigid erection and are also involved in the process of ejaculation. Many people, including many doctors, are unaware of the significant role these muscles play in sexual function, especially in the context of diabetes. Diabetic neuropathy can weaken the nerve signals to these muscles, causing them to lose tone and function over time. Targeted pelvic floor therapy is a non-invasive, drug-free method to directly combat this muscular decline, essentially rehabilitating the very muscles responsible for keeping an erection firm. The science behind how pelvic floor therapy improves erections is based on simple biomechanics and neurology. The ischiocavernosus muscles are attached to the base of the penis. When they contract, they press on the deep dorsal vein of the penis, compressing it against the underlying bone. This compression is crucial because it prevents blood from flowing out of the erect penis, a condition known as veno-occlusive dysfunction or venous leak. If these muscles are weak, they cannot effectively compress this vein, and blood escapes, causing the erection to soften or be lost quickly. The bulbospongiosus muscle, which surrounds the bulb of the penis, also contributes by contracting rhythmically during ejaculation and by helping to push blood into the shaft of the penis during erection. In men with diabetes, two things happen. First, diabetic neuropathy can diminish the nerve impulses that control these muscles, leading to atrophy or a weakening of the muscle tissue. They become less responsive and weaker over time. Second, poor vascular health can reduce the oxygen supply to these muscles, further impairing their function. Targeted pelvic floor exercises work by increasing blood flow to the pelvic region, which nourishes the muscles and nerves. The repetitive contraction and relaxation of the muscles act like a workout, increasing their strength, endurance, and tone. This process can also help to reestablish and strengthen the neuromuscular pathways, the connection between the brain and the muscles, which may have been compromised by neuropathy. A stronger, more responsive pelvic floor can more effectively trap blood in the penis, leading to harder, more sustainable erections. I know there's a lot of debate online about metformin. We're going to cut through the noise and look at the clinical studies. Research has confirmed this. A landmark study published in the British Journal of General Practice found that pelvic floor muscle training was an effective treatment for a significant percentage of men with long-term erectile dysfunction. The consequence of neglecting the health of your pelvic floor muscles is that you are ignoring a key mechanical component of erectile function. You can improve your blood flow through diet and medication, but if the muscles responsible for trapping that blood in the penis are weak, you will still struggle to maintain a rigid erection. This is often the missing piece of the puzzle for many men. They may find that medications help them achieve an erection, but they can't maintain it long enough for satisfactory intercourse. This condition, often diagnosed as venous leak, can be incredibly frustrating and can lead to performance anxiety, which only worsens the problem. Men may assume the issue is purely vascular or that their medication has stopped working, when in fact, the underlying problem is a weakened muscular system. This can lead to a cycle of escalating treatments, moving towards more invasive options like injections or implants, when a simpler, non-invasive solution might have been effective. Ignoring the pelvic floor is like trying to fix a leaky tire by just adding more air without patching the hole. You are not addressing the mechanism of failure. This muscular weakness is a direct, treatable consequence of diabetes, and failing to address it leaves a significant therapeutic opportunity on the table, contributing to feelings of hopelessness and treatment failure. The solution is to seek out a qualified pelvic floor physical therapist, ideally one who has experience working with male patients and erectile dysfunction. This is not something to just guess at by watching a generic online video. A proper assessment is key. A therapist can use biofeedback and other tools to help you identify and isolate the correct muscles. Many men, when trying to do Kegels on their own, end up contracting the wrong muscles, like their abdominals or glutes, which is completely ineffective. A therapist will teach you specific exercises tailored to your condition. The basic exercise involves squeezing the muscles you would use to stop the flow of urine midstream, holding the contraction for a few seconds, and then relaxing. The key is to do this without holding your breath or tensing other muscles. A typical regimen might involve multiple sets of these contractions performed daily. A therapist can also guide you on progressing the exercises, increasing the hold time and repetitions as your muscles get stronger. They may also incorporate exercises to improve the coordination and endurance of these muscles. Consistency is absolutely critical. It can take several weeks to a few months of daily practice to see a significant improvement, but the results can be dramatic and long-lasting. This is a proactive, empowering approach that puts a degree of control back in your hands. It directly addresses a physical deficit caused by diabetes and can significantly enhance the effectiveness of all other treatments you may be undertaking. Optimize your hormone profile. This is about much more than just checking a single testosterone level. Optimizing your hormone profile involves a comprehensive evaluation of your entire endocrine system as it relates to sexual function. While low testosterone, or hypogonadism, is a major focus, it's also crucial to look at other key hormones like estradiol, which is a form of estrogen, prolactin, and thyroid hormones. In men with diabetes, particularly those who are overweight, the hormonal balance can be significantly disrupted. It's not always a simple case of the testes not producing enough testosterone. There's often a complex interplay of factors, including increased conversion of testosterone to estrogen in fat tissue, and the impact of insulin resistance on hormone production and signaling. Optimizing your hormone profile means working with a knowledgeable physician to get a complete picture and then developing a targeted strategy to restore a healthy, youthful balance. This may or may not involve testosterone replacement therapy, but it always involves addressing the root causes of the imbalance, such as excess body fat and insulin resistance. The science connecting hormones to erectile function in diabetics is multifaceted. Testosterone is a primary driver of libido, or sexual desire. Low testosterone directly reduces your interest in sex, which is often the first step in the arousal process. But it also plays a direct physiological role in the penis itself. Testosterone helps maintain the health of the smooth muscle tissue within the corpus cavernosum and supports the production of nitric oxide. So, low levels can contribute to both a lack of desire and a poor physical response. However, the story is more complex in men with diabetes and obesity. Fat cells contain an enzyme called aromatase. This enzyme converts testosterone into estradiol. The more body fat a man has, the more aromatase activity there is, and the more of his precious testosterone is being turned into estrogen. High estradiol levels in men can further suppress the body's natural testosterone production signals from the pituitary gland, creating a vicious cycle. This leads to a state of both low testosterone and relatively high estrogen, a combination that is disastrous for erectile function and overall health. Furthermore, insulin resistance itself can impair testicular function. Prolactin is another important hormone. High levels, a condition called hyperprolactinemia, can suppress testosterone and cause erectile dysfunction. Finally, your thyroid gland acts as the master regulator of your metabolism. Both an underactive thyroid, hypothyroidism, and an overactive thyroid, hyperthyroidism, can profoundly impact energy levels, mood, and sexual function. Understanding this complex web of interactions is key to effective treatment. The consequence of having an unbalanced hormone profile is a significant and often insurmountable barrier to healthy sexual function. You can have perfect blood flow, but if your brain isn't sending strong signals of desire due to low testosterone, the entire process may not even begin. This is a crucial point that is often missed. Men may be focused entirely on the mechanical aspects of an erection while ignoring the neurological and psychological drive that initiates it. Low testosterone also contributes to fatigue, depression, and a loss of muscle mass, all of which indirectly worsen sexual function and overall quality of life. Furthermore, if you are started on testosterone replacement therapy without addressing a high estradiol level, the treatment may be ineffective or even counterproductive. The extra testosterone you are taking can simply be converted into more estrogen by the aromatase enzyme in your fat tissue, worsening the problem. This can lead to side effects like water retention and breast tissue growth, gynecomastia, without any improvement in erections or libido. It highlights the danger of a simplistic approach. Simply prescribing testosterone without a full hormonal workup and a plan to manage potential side effects and underlying causes is poor medical practice and often leads to patient frustration and abandonment of treatment. It's a prime example of treating a number without treating the patient. The solution begins with getting the right tests done. This is not the time for a simple, single testosterone check. You need a comprehensive hormone panel that includes, at a minimum, total testosterone, free testosterone, the unbound active form, estradiol, specifically the sensitive assay for men, sex hormone binding globulin, SHBG, luteinizing hormone, LH, follicle stimulating hormone, FSH, prolactin, and a full thyroid panel, TSH, free T3, free T4. These tests should ideally be done in the morning when testosterone levels are at their peak. The next step is to find a doctor, an endocrinologist or a urologist with expertise in hormonal health, who knows how to interpret these results in the context of your diabetes and overall health. If low testosterone is confirmed, testosterone replacement therapy, TRT, might be an option, delivered via injections, gels, or patches. However, if estradiol is high, your doctor may also consider prescribing an aromatase inhibitor to block the conversion of testosterone to estrogen. The most crucial part of this solution, however, is addressing the root cause. For many men with type 2 diabetes, this means aggressive weight loss. Losing body fat, particularly visceral fat around the abdomen, is the single most effective way to naturally lower aromatase activity, reduce estrogen, and increase testosterone. Every pound of fat you lose helps to restore your natural hormonal balance. This, combined with precise glycemic control and a vasoprotective diet, creates a powerful synergistic effect that can dramatically improve both your hormonal profile and your erectile function. Explore second-line medical therapies. When oral medications like sildenafil or tadalafil are not effective, which can happen in up to 50% of men with diabetes, it is not the end of the road. It's time to explore what are known as second-line medical therapies. These are proven, effective treatments that work through different mechanisms to produce a strong erection. The two primary options in this category are intracavernosal injection therapy, also known as ICI, and intraurethral therapy, using a product called MUSE. These methods bypass some of the damaged nerve and blood vessel pathways that limit the effectiveness of oral pills. They are more localized, delivering medication directly to the penis to induce an erection. While they may sound intimidating at first, they are widely used, have very high success rates, and can be a life-changing solution for men who thought they had run out of options. These are not experimental treatments. They are established, FDA-approved medical procedures that restore sexual function for hundreds of thousands of men. The science behind these therapies is direct and powerful. Intracavernosal injection therapy involves using a very fine, short needle, similar to an insulin needle, to inject a small amount of a vasodilator medication directly into the corpus cavernosum, the spongy tissue on the side of the penis. The most common medications used are alprostadil, papaverine, and phentolamine. Often, they are combined into a powerful mixture known as bimix or trimix. Alprostadil is a synthetic version of prostaglandin E1, a potent vasodilator that relaxes the smooth muscle in the arteries and tissues of the penis, allowing blood to flow in rapidly. Papaverine and phentolamine work through different but complementary pathways to also promote smooth muscle relaxation and increase arterial blood flow. Because the medication is delivered directly to the target tissue, it bypasses the need for the nitric oxide pathway that is often impaired in men with diabetes. This is why it can work even when oral pills fail. The erection produced is purely pharmacological and typically appears within 5 to 15 minutes, lasting for 30 to 60 minutes. Intraurethral therapy with MUSE, which stands for Medicated Urethral System for Erection, involves a different delivery method. A small, pre-filled applicator is used to insert a tiny medicated pellet of alprostadil into the urethra, the tube through which you urinate. The medication is then absorbed through the urethral wall into the surrounding erectile tissues, where it causes vasodilation and produces an erection, usually within 10 to 20 minutes. Understanding the glycemic index is key, but this next tip on food sequencing is what makes the biggest immediate difference. The consequence of being unaware of or unwilling to consider these second-line therapies is often the complete cessation of a healthy sex life. Men may feel a profound sense of failure and hopelessness when oral medications don't work. They may believe that their sexual function is permanently lost, which can lead to depression, anxiety, and severe strain on intimate relationships. This is a tragic outcome because, in most cases, it is entirely unnecessary. The belief that pills are the only option is a significant barrier to effective care. This can lead men to seek out unproven and potentially dangerous supplements or herbal remedies out of desperation. It's crucial to understand that the failure of oral medications is not a personal failure. It is a predictable outcome given the complex pathophysiology of diabetic erectile dysfunction. The damage to the nitric oxide pathway is a real, physical impairment. To not progress to the next logical step in treatment is to give up prematurely. The psychological toll of this can be immense, impacting self-esteem and masculinity. It can create a wedge between partners and lead to a complete avoidance of intimacy, further damaging the relationship. The silence and stigma surrounding these treatments prevent many men from even asking their doctor about them, leading to years of unnecessary suffering. The solution is to have an open and honest conversation with a urologist. A urologist is the specialist best equipped to discuss, prescribe, and teach you how to use these second-line therapies. They will conduct a thorough evaluation to determine if you are a good candidate and which option is best for you. For injection therapy, the initial injection is always done in the doctor's office. The medical staff will teach you the proper technique for drawing up the medication and performing the self-injection. While the idea of a needle can cause anxiety, most men are surprised to find that because the needle is so fine and the injection site has few nerve endings, it is virtually painless. The doctor will work with you to find the precise dose that gives you a firm, lasting erection without causing an erection that lasts too long, a condition known as priapism, which is the main potential side effect. For MUSE, the application process is also taught in the office. Both methods require a prescription and a willingness to learn a new skill. But the payoff can be the restoration of a spontaneous and satisfying sex life. Of course, everyone's journey with carb counting is different. I'd be very interested to hear what's worked for you. Share your single best tip in the comments below. It could really help someone else reading this. These therapies are powerful tools that put you back in control, providing a reliable on-demand solution that can bridge the gap while you continue to work on the foundational lifestyle and health improvements. Address the psychological component. This involves actively recognizing and treating the significant mental and emotional aspects that accompany and exacerbate erectile dysfunction, particularly in the context of a chronic illness like diabetes. It's about understanding that the brain is the most important sex organ. Issues like performance anxiety, depression, stress, and relationship conflicts can be both a cause and a consequence of erectile difficulties. For a man with diabetes, there's the added psychological burden of managing a demanding chronic condition, which can be a significant source of stress and fatigue. Addressing the psychological component means moving beyond a purely mechanical view of erections and acknowledging the powerful connection between your mind, your emotions, and your sexual response. This can involve strategies ranging from simple stress management techniques to formal counseling or sex therapy with a qualified professional. The science of how psychology impacts erections is rooted in the autonomic nervous system, which has two main branches: the sympathetic and the parasympathetic. The parasympathetic system is responsible for the rest and digest functions, and it is the dominant system required for an erection to occur. It promotes relaxation and allows blood to flow into the penis. The sympathetic nervous system, on the other hand, governs the fight or flight response. When you are stressed, anxious, or fearful, your body releases hormones like adrenaline and cortisol, which activate the sympathetic system. This activation causes vasoconstriction, the tightening of blood vessels, throughout the body, including in the penis, as your body diverts blood to your muscles in preparation for a perceived threat. This is a direct physiological block to achieving an erection. Performance anxiety is a classic example of this. A man has one negative experience, perhaps due to the underlying physical effects of his diabetes. He then becomes anxious that it will happen again. The next time he is in a sexual situation, that anxiety triggers his sympathetic nervous system, releasing adrenaline, constricting his blood vessels, and making an erection impossible. This creates a self-fulfilling prophecy and a vicious cycle of failure and anxiety. Depression, which is twice as common in people with diabetes, also plays a major role. Depression can lower libido and energy levels, and it disrupts the neurotransmitters, like dopamine and serotonin, that are involved in feelings of pleasure and arousal. Furthermore, the constant mental effort and worry associated with managing blood sugar, medication, and diet can create a state of chronic stress that keeps the sympathetic nervous system on high alert, making sexual arousal and function very difficult. The consequence of ignoring the psychological dimension is that you can have a body that is physically capable of an erection, yet still be unable to perform. You might have excellent glycemic control, a perfect hormone profile, and be using effective medical treatments. But if performance anxiety or stress hijacks your nervous system at the critical moment, none of it will matter. This is one of the most frustrating scenarios for patients and their partners. It can lead to the incorrect assumption that the physical treatments are not working, causing men to abandon effective therapies. The strain on relationships can be immense. The partner may feel rejected or that they are no longer attractive, leading to communication breakdowns and emotional distance. The man may feel ashamed, inadequate, and withdrawn. This can create a cycle of blame, frustration, and avoidance of intimacy that can destroy even the strongest relationships. The bedroom becomes a place of anxiety and pressure rather than pleasure and connection. Failing to address the psychological component means you are only treating half of the problem. It is like meticulously tuning up an engine but ignoring the fact that the driver has a foot planted firmly on the brake. The solution is a multi-pronged approach that addresses both your internal mental state and your relationship dynamics. The first step is open communication, talking honestly with your partner about your fears, frustrations, and the physical realities of your condition can relieve an enormous amount of pressure. It reframes the issue from a personal failure to a shared challenge that you can face together. Shifting the focus of intimacy away from just intercourse and towards other forms of sensual and emotional connection can also reduce the pressure and anxiety associated with performance. For managing personal stress and anxiety, techniques like mindfulness meditation, deep breathing exercises, and regular physical activity can be incredibly effective. These practices help to calm the sympathetic nervous system and promote a state of relaxation conducive to arousal. If these self-help strategies are not enough, seeking professional help is a sign of strength, not weakness. A sex therapist or a counselor who specializes in chronic illness can provide you with specific tools and strategies, such as cognitive behavioral therapy, to break the cycle of performance anxiety. They can help you challenge negative thought patterns and reframe your approach to sex. Couples counseling can also be extremely beneficial, providing a safe space to improve communication and rebuild intimacy. Your primary care doctor or urologist can be a great resource for a referral to a qualified therapist. Acknowledging and actively managing the psychological component is not a sign of weakness. It is an essential part of a comprehensive and intelligent treatment plan. Consider penile implant surgery. This is the definitive final-line treatment for erectile dysfunction when all other less invasive therapies have failed or are not suitable. A penile implant, also known as a penile prosthesis, is a medical device that is surgically placed entirely inside the body. It allows a man to have an erection whenever he chooses, for as long as he chooses. There are two main types: the inflatable implant and the malleable, or semi-rigid, implant. This is not a penis transplant or an experimental procedure. It is a well-established surgical solution that has been in use for over 4 decades and has undergone significant technological advancement. For men with severe, irreversible erectile dysfunction, often resulting from long-standing diabetes, a penile implant can be a permanent and highly effective solution that restores sexual function and spontaneity. It is considered the gold standard treatment in terms of patient and partner satisfaction when other treatments have failed. The science and engineering behind modern penile implants are quite sophisticated. The most common type, the 3-piece inflatable penile prosthesis, is a hydraulic system. It consists of 3 components connected by silicone tubing. 2 cylinders are surgically placed inside the corpus cavernosum, the 2 chambers in the shaft of the penis that normally fill with blood. A small pump is discreetly placed inside the scrotum, alongside the testicles. A reservoir containing sterile saline solution is placed in the lower abdomen, behind the abdominal muscles. When a man wants to have an erection, he simply squeezes the pump in his scrotum a few times. This action transfers the saline from the reservoir through the tubing and into the cylinders in the penis. As the cylinders fill, they expand, creating a hard, rigid erection that is very similar in appearance and sensation to a natural erection. The erection will last until he decides to deflate it. To do so, he presses a deflation button on the pump, which allows the fluid to flow back into the reservoir, and the penis returns to a soft, flaccid state. The second type, the malleable implant, consists of 2 flexible rods that are placed inside the penis. These rods keep the penis in a constant state of firmness, but they can be easily bent. The man can bend the penis up and away from his body for intercourse, and then bend it down and conceal it against his body for daily activities. This option is simpler mechanically, but provides less of a natural flaccid state compared to the inflatable device. The consequence of not considering a penile implant for a man who has exhausted all other options is the permanent loss of the ability to have penetrative sex. This can be a devastating blow to a man's quality of life, self-esteem, and intimate relationships. It can lead to a state of resignation and hopelessness, where a fulfilling sex life is seen as something that is forever in the past. This often happens after years of struggling with pills that don't work, injections that become cumbersome, or vacuum devices that are found to be awkward and unromantic. The man and his partner may simply give up, leading to a medical divorce where physical intimacy ceases entirely. This is a profound loss that can have far-reaching psychological consequences. The reluctance to consider a surgical option can stem from fear, misinformation, or a lack of awareness that such an effective solution even exists. Men may worry about the cosmetic outcome or the mechanical reliability of the device. However, modern implants are completely concealed within the body, and studies show mechanical reliability rates of over 95% at 5 years. Choosing not to explore this option, when appropriate, means accepting a lower quality of life that, for many, is not a necessary outcome. The solution is to get a surgical consultation with a high-volume, experienced urological surgeon who specializes in prosthetic urology. This is a subspecialty, and it is critical to find a surgeon who performs many of these procedures regularly, as experience is directly linked to better outcomes and lower complication rates. During the consultation, the surgeon will perform a full evaluation, discuss the risks and benefits of the surgery, and help you decide which type of implant is best suited for your anatomy, lifestyle, and dexterity. They will answer all of your questions and address any fears or concerns you or your partner may have. The surgery itself is typically performed on an outpatient basis or with a single overnight stay in the hospital. Recovery usually takes about 4 to 6 weeks, after which the device can be activated and used. It is crucial to have realistic expectations. The implant provides excellent rigidity for intercourse, but it does not change the length of the penis or restore natural sensation or ejaculation if they have been lost due to severe neuropathy. However, for most men, the ability to achieve a reliable, on-demand erection is transformative. Patient satisfaction rates for penile implants are consistently the highest of any erectile dysfunction treatment, often exceeding 90%. For the right candidate, the man with severe ED for whom other treatments have failed, it is not a last resort, but rather a definitive and highly satisfying permanent solution. If you enjoyed this video, you will probably also like this one. Please subscribe to this channel and let us know in the comments your thoughts. Thanks for watching.